Hello, my name is Jonathan Miller. I'm the director of the Functional and Restorative Neurosurgery Center at University Hospital's Case Medical Center and Case Western Reserve University School of Medicine. This is a presentation about microvascular decompression for trigeminal neuralgia. The goal of this procedure is to expose the cerebellopontine angle via a retrosigmoid approach to address any neurovascular conflicts on the trigeminal nerve. It is possible to perform the case from a supine position as long as the head is rotated and flexed. The dura is opened along the transverse and sigmoid sinuses. Once the cranial and dural opening are performed, the angle between the petrous bone and tentorium will be visualized, along with the superior petrosal vein, which is cauterized and divided to expose the trigeminal nerve. At this point, the nerve should be explored to mobilize any offending arteries and hold them away from the nerve using shredded Teflon. The patient in this case is a 68-year-old man with a 7-year history of type 1A trigeminal neuralgia affecting the right side of the face in the second and third distribution. The pain was triggerable, lancinating, memorable in onset, and associated with pain-free intervals. He initially responded well to carbamazepine, but the medication became less effective over time, and he developed severe side effects. Compression of the right trigeminal nerve by the superior cerebellar artery was visible on MRI. The patient is positioned supine with the head turned to the left, flexed and rotated, and an incision is planned 2 finger breadths behind the ear, centered on the tragus. Brainstem auditory evoked potentials are monitored throughout the case. The incision is made and the muscles reflected to visualize the asterion, and a high-speed drill is used to expose the dura at the junction of the transverse and sigmoid sinuses, taking care to place bone wax within the mastoid air cells. The dura is opened along the sinuses, and a cottonoid patty is gently advanced into the cistern to allow cerebrospinal fluid to escape, which facilitates relaxation of the brain. For this reason, a retractor is generally not necessary. Gentle retraction of the cerebellum will reveal the petrosal vein, which is cauterized and then sharply dissected, and this will allow wide exposure of the trigeminal nerve for exploration and decompression. The root entry zone is thoroughly explored for any signs of arterial compression. In this case, we see the branch of the superior cerebellar artery lying within the axilla of the root entry zone. Meticulous dissection of the arachnoid is necessary for full exploration and to allow mobilization of the artery. Once this has been done, it's possible to lift the artery from behind the nerve and place it on top of the nerve where it will no longer press against the root entry zone. A thorough exploration is performed to verify that there are no other points of contact. Small veins that are compressing the nerve can generally be sacrificed safely, but arteries should be preserved. Once the artery has been mobilized, several pieces of shredded Teflon can be placed to keep it in its new location and prevent it from falling back against the nerve. Generally, the Teflon can be placed initially using a micro bayonet and then manipulated into position using dissecting tools. The shredded Teflon serves the purpose of holding the artery in its new location relative to the nerve. Additional pieces of shredded Teflon can be added as necessary to ensure that the artery and the nerve are held away from each other. Once all points of neurovascular conflict have been addressed, the dura is closed in a watertight manner, a cranioplasty is performed, and the wound is closed. 2 years after the operation, the patient is free of pain and off all medications.